Pay attention to the woman in the blue scrubs moving through Ward 7C. Notice how her hands rest gently on the IV stand, how she adjusts the pillow behind the elderly man's head, how she smiles at him, a warm, practiced smile that speaks of years spent at bedsides. This is her 6th patient visit tonight. In 43 minutes, this man will stop breathing, and she will be the one to discover him.
Not now, please. Fuck. Michael, call the duty doctor, quick!
But here's what she doesn't know yet. Tonight, for the first time in 18 months, someone is watching. St. Raphael's Medical Center, Manchester, England, March 2018. Over the course of 13 months, the overnight mortality rate in the cardiac care unit increased by 370%. 17 patients, all under the age of 75, all in stable condition, experienced sudden, unexplained respiratory arrests between the hours of midnight and 6 a.m. 17 families received phone calls in the dark hours before dawn. 17 times the same nurse appeared in the doorway to deliver the news with tears in her eyes. Her name was Elizabeth Marsh, and for more than a year she was killing the people she'd sworn to protect. But before we understand how she did it, we need to understand what makes a human body stop breathing, because the mechanism of death here is more sinister than you might imagine. Your respiratory system operates on a feedback loop so precise, so finely calibrated, that interfering with it leaves almost no trace. At the base of your brain, in a region called the medulla oblongata, sits a cluster of neurons that monitor the carbon dioxide levels in your blood. When CO2 rises, these neurons fire. They send signals down your spinal cord to the diaphragm and intercostal muscles between your ribs. You inhale. Oxygen floods your lungs, diffuses across microscopic membranes into your bloodstream, and binds to hemoglobin molecules that carry it to every cell in your body. Then you exhale, expelling CO2. This cycle repeats roughly 16 times per minute every minute of your entire life. You don't think about it, you don't control it, it just happens, unless someone stops it. There are 3 ways to interrupt this system. The first is mechanical, block the airway physically through strangulation or suffocation. Violent, obvious, leaves ligature marks, petechiae in the eyes, clear signs of struggle. The second is neurological, damage the brainstem or sever the spinal cord. Equally obvious, visible on, to detect. Certain substances interfere with the electrical signals that tell your muscles to contract. They slide into the receptor sites on your muscle cells like a key into a lock, but they don't turn. They just sit there, blocking the real signal from getting through. Your brain screams at your diaphragm to contract, but the message never arrives. Your lungs stop moving. Your blood oxygen drops. Hypoxia sets in. Without intervention, you have 3 to 4 minutes before irreversible brain damage occurs, 6 to 8 minutes before death. The drug that does this most efficiently is called vecuronium bromide. It's a neuromuscular blocking agent, what anesthesiologists call a paralytic. In surgery, it's essential. You can't have a patient breathing on their own while a machine is breathing for them. The 2 systems fight each other. So before the surgeon makes the first incision, the anesthesiologist administers a paralytic. The patient's muscles go completely slack. A breathing tube is inserted. A ventilator takes over. The surgery proceeds, but here's the crucial detail. Vecuronium doesn't cause pain. It doesn't cause fear. It only causes paralysis. If you gave it to someone who was awake, they would feel their chest stop moving. They would feel themselves unable to draw breath. But they couldn't scream. They couldn't move. They couldn't fight. They would simply lie there, fully conscious, suffocating in absolute silence. And when it's administered in the right dose to a sleeping patient, it looks exactly like a natural respiratory arrest. The drug metabolizes quickly. Within 2 hours, it's broken down into compounds that occur naturally in the body during cell death. Unless the autopsy happens within 12 to 18 hours, and unless the pathologist specifically tests for it using gas chromatography mass spectrometry, it vanishes. The tox screen comes back clean. The death certificate reads acute respiratory failure or cardiac arrest. The family grieves. The hospital reviews the case, finds no fault, and moves on. 17 times this happened at St. Raphael's, and no one suspected a thing. Let's rewind to October 2016. Let's meet the woman at the center of this. Elizabeth Marsh was 42 years old, a registered nurse for 19 years, specializing in cardiac care. Her performance reviews were exemplary. Her colleagues described her as dedicated, compassionate, and meticulous. She volunteered for extra shifts. She stayed late to help families understand discharge instructions. She organized the staff Christmas party and the charity fun run. She had 2 children, ages 12 and 15. Her husband was a secondary school teacher. They lived in a semi-detached house in Stockport with a garden where she grew tomatoes. By every observable metric, Elizabeth Marsh was exactly who you'd want taking care of your grandmother at 3 in the morning. But something had changed. Her marriage was disintegrating. Her husband had discovered she'd been having an affair with a hospital administrator, a relationship that had ended badly 6 months earlier when the man had chosen to reconcile with his wife. Elizabeth had become depressed. She'd started therapy but stopped after 4 sessions. Her friends noticed she seemed withdrawn. She stopped attending social events. She called in sick more frequently. When she was at work, she seemed distracted, irritable, and then the deaths started. The first was Harold Pemberton, age 67, retired postal worker, admitted for atrial fibrillation. Stable condition, expected discharge in 2 days. His heart rhythm had been successfully converted. He was sleeping comfortably. Elizabeth checked on him at 1:15 a.m. during her rounds. At 2:30 a.m., she returned to check his vitals and found him unresponsive. She called a code. The crash team arrived within 90 seconds. They worked on him for 28 minutes. Harold Pemberton was pronounced dead at 3:07 a.m. The attending physician reviewed the case. Harold had a history of heart disease. Sudden cardiac death, while tragic, wasn't unheard of in his demographic. The family was devastated but didn't question the explanation. An autopsy wasn't performed. The cause of death seemed clear, and the family didn't request one. 3 weeks later, it happened again. Margaret Chen, age 71, admitted for unstable angina. Responding well to treatment, Elizabeth discovered her in respiratory arrest at 4:20 a.m. Another code, another death. Another grieving family told that sometimes, despite everyone's best efforts, the heart just gives out. The third death occurred in January 2017. Thomas Wickham, age 59, post-MI, recovering. Beautifully, his cardiologist had told his wife that morning that he'd likely go home by the weekend. Elizabeth found him at 1:40 a.m., not breathing, pupils fixed and dilated. This time, the resuscitation failed even faster. 12 minutes. Time of death, 1:52 a.m. Now the hospital administrators were paying attention, not because they suspected foul play, but because 3 unexpected deaths in a single ward in 3 months was statistically unusual. They conducted a morbidity review. They examined the cases for common factors. All 3 patients had documented cardiac conditions. All 3 deaths occurred overnight. All 3 had been under Elizabeth's care when they arrested. But Elizabeth had been a nurse for nearly 2 decades. She'd been present for dozens of patient deaths. That's what happens when you work in cardiac care. People die. The review committee noted the cluster but found no evidence of negligence or error. They recommended additional training for the overnight staff on early recognition of clinical deterioration. They moved on. Elizabeth didn't stop. Between February and August 2017, 8 more patients died on her shifts. The hospital's mortality review board was now meeting monthly. Something was clearly wrong, but no one could identify what. The deaths showed no clear pattern. Different ages, different diagnoses, different times of night. Some patients had been on the ward for days, others had just arrived. The only consistent factor was that all of them had been stable before their arrests. The hospital brought in an external consultant, a cardiologist from Liverpool who specialized in sudden cardiac death. He reviewed every case file. He looked at medications, lab values, monitor strips, nursing notes. His conclusion: while the cluster was statistically improbable, each individual death had a plausible medical explanation. He suggested the hospital implement a rapid response team and increase monitoring equipment. He found no evidence of wrongdoing. But Dr. Ananya Patel, the head of the cardiac care unit, wasn't satisfied. She'd been a physician for 26 years. She knew her patients, she knew her staff, and she knew that something about these deaths felt wrong. The patients weren't just dying, they were dying quietly. In cardiac arrest, patients typically show warning signs: increased heart rate, decreased oxygen saturation, abnormal rhythms on the monitor. These patients showed none of that. They simply stopped breathing. In September 2017, Dr. Patel did something unusual. She started keeping her own log. Every time a patient died on the overnight shift, she noted the date, time, location, and which nurse had been assigned to that patient. She didn't tell anyone what she was doing, not the hospital administration, not her colleagues. She just watched and documented. By December, the pattern was undeniable. 13 deaths on Elizabeth Marsh's shifts. 2 deaths when Elizabeth was on vacation. 0 deaths on nights when Elizabeth called in sick. Dr. Patel took her log to the medical director. His name was James Whitworth, and he'd been in hospital administration for 32 years. He looked at the spreadsheet. He looked at Dr. Patel. and he said the words that no hospital administrator ever wants to say: "We need to call the police." On January 11, 2018, Detective Inspector Sarah Connolly of the Greater Manchester Police received a phone call that would launch one of the most complex investigations of her career. A hospital was reporting suspected serial murder by a member of its staff. The suspect was still working, still had access to patients, and if the hospital's timeline was correct, had already killed at least 13 people. D.I. Connolly's first move was to ensure patient safety without alerting the suspect. Elizabeth was quietly reassigned to administrative duties, told it was temporary due to staffing restructuring. She wasn't suspicious. She seemed relieved, actually. She told a colleague she was exhausted and the break would be good. Then Connolly assembled her team. She needed detectives, yes, but she also needed medical experts, forensic pharmacologists, and data analysts. Because proving that a healthcare worker murdered patients is phenomenally difficult. You're not dealing with a crime scene in the traditional sense. You're dealing with a hospital where death is expected and where hundreds of people have legitimate access to the victims. The first question was, how? If Elizabeth was killing patients, what method was she using? It had to be something that was available in a hospital, something she could access without raising suspicion, and something that would be difficult to detect post-mortem. The forensic team started with the obvious suspects: opioids, morphine, fentanyl. An overdose would suppress respiration, but opioid overdoses have a characteristic presentation: pinpoint pupils, a specific pattern of respiratory depression. The victims hadn't shown that. Plus, opioids would show up on a standard toxicology screen, and several of the victims had been autopsied. All had come back clean. What about potassium? A large bolus of potassium chloride injected directly into an IV line causes the heart to stop. It's been used in murders before, notably by Beverly Allitt, the British nurse who killed 4 children in 1991. But potassium is difficult to detect because it occurs naturally in the body, especially after death as cells break down. However, it causes a characteristic arrhythmia before the heart stops, tall, peaked T waves on the ECG. The monitors at St. Raphael's would have captured that. They hadn't. Then someone suggested neuromuscular blockers. Dr. Michael Torres, the forensic pharmacologist consulting on the case, explained it to the team. Drugs like vecuronium, rocuronium, succinylcholine, they're kept in every operating room and in most intensive care units. They cause complete paralysis within 60 to 90 seconds. Respiratory arrest follows immediately, and unless you test for them specifically within a narrow window, they're nearly impossible to detect. The problem was, all the victims had already been buried or cremated. There were no tissue samples to test, no way to confirm the theory. D.I. Connolly made a decision that was both ethically complex and operationally necessary. They would exhume the bodies. Between January and March 2018, 7 bodies were exhumed from cemeteries across Greater Manchester. The families were told only that new evidence had emerged in their loved one's death, and that further testing was required. The remains were taken to the forensic pathology lab at Manchester Royal Infirmary. Dr. Emily Richardson, the Home Office pathologist assigned to the case, performed the re-examinations. In 3 of the 7 cases, the bodies were too decomposed for meaningful analysis. But in 4 cases, patients who had died within the previous 6 months, she found something. Trace amounts of vecuronium metabolites in liver and kidney tissue. The levels were low, at the very edge of detectability, but they were there, and there was no reason for them to be there. None of these patients had undergone surgery. None had been intubated. None had been prescribed neuromuscular blockers for any legitimate medical reason. They'd been murdered. Now the investigation shifted from if to how exactly. The police obtained a warrant to search Elizabeth Marsh's home and locker. They found nothing, no drugs, no syringes, no evidence. But they did find something interesting on her work computer. She'd accessed the medical records of 12 patients who had died on other nurses' shifts, patients she'd had no clinical responsibility for. She'd been reading about their deaths. The theory that emerged was this: Elizabeth had been stealing vecuronium from the anesthesia supply room. Hospital inventory controls for controlled substances like morphine are strict. Every dose is logged, counted, double-checked. But neuromuscular blockers aren't controlled substances in the same way. They're prescription only, yes, but the tracking is less rigorous. A vial goes missing, it's assumed to be a documentation error. Elizabeth would take a vial, draw up a small dose, 2 to 3 milligrams, enough to cause paralysis, but not so much that it would be obviously detectable, and carry it in her scrubs pocket. During her rounds, she'd enter a patient's room. She'd check their IV line, and while she stood there, adjusting the flow rate or changing the bag, she'd inject the vecuronium into the IV port. Within 90 seconds, the patient would stop breathing. Elizabeth would leave the room. She'd continue her rounds. 20 minutes later, she'd return to check on them, and she'd discover them in arrest. She'd call the code, she'd perform CPR, she'd comfort the family, she'd cry real tears. Because here's the thing the psychological profile later revealed. Elizabeth wasn't a sadist. She didn't enjoy watching them die. She enjoyed being the one who tried to save them. She enjoyed the adrenaline of the code response. She enjoyed the gratitude of families who thanked her for her compassionate care in their loved ones' final moments. She enjoyed being seen as the good nurse, the caring one, the one who went above and beyond. This is what psychologists call hero syndrome, or attention-seeking behavior in a medical setting. It's been documented in dozens of cases of healthcare serial killers. They create the emergency so they can be the hero who responds to it. And when the patient dies, despite their efforts, they receive sympathy and admiration for how hard they tried. But D.I. Connolly still needed proof. Trace metabolites in decomposed tissue and a psychological profile weren't enough for a conviction. They needed to catch Elizabeth in the act, so they set a trap. In March 2018, this hospital installed covert CCTV cameras in Ward 7C. The cameras were hidden in smoke detectors and air vents. They covered every angle of the hallway and every patient room. The feeds were monitored in real time by police officers in an unmarked van parked behind the hospital. Elizabeth was told her administrative assignment was ending and she'd be returning to floor nursing. She seemed happy about it. She told a colleague she'd missed patient care. Her first shift back was March 14, 2018, 7 p.m. to 7 a.m. The police had arranged for 2 undercover officers to be admitted as patients. Both were healthy male officers in their 50s, posing as cardiac patients. They wore hidden body cameras. Their rooms were under constant video surveillance. 4 armed officers were positioned in the hospital, disguised as visitors and maintenance workers. If Elizabeth attempted to harm either officer, the team would move in immediately. But Elizabeth was smart. She seemed to sense something was off. She was polite, professional, efficient. She did her rounds. She charted her notes. She didn't enter the undercover officers' rooms alone. She always brought a nursing assistant with her. At 6:40 a.m., her shift ended without incident. The team regrouped. Maybe she'd been spooked by the reassignment. Maybe she'd stopped. Maybe they'd never get the evidence they needed. They decided to continue surveillance, but to pull the undercover officers. It was too resource-intensive, and the risk to real patients was too high. For 3 weeks, Elizabeth worked her shifts under hidden camera surveillance. Nothing happened. No unexpected deaths, no suspicious behavior. And then, on April 9th, 2018, at 2:17 a.m., she walked into room 7C18. The patient was an 81-year-old man named Arthur Whitfield. He'd been admitted 3 days earlier with atrial fibrillation. He was stable, expected to go home in the morning. His family had visited that evening. They'd brought him his favorite biscuits. He'd told them he felt fine, just tired. Elizabeth entered the room alone. The camera, positioned in the upper corner near the window, captured everything. She's checking his monitor. Her back is to the camera, but you can see her shoulders moving. She's reaching toward the IV line. Her hand hovers over the injection port. She glances toward the door. The hallway is empty. She reaches into her pocket. She withdraws a syringe. She uncaps it with her teeth. She inserts the needle into the port. She depresses the plunger. 3 seconds. She withdraws the needle, recaps it, puts it back in her pocket. She adjusts Arthur's blanket. She turns and walks out of the room. In the van, D.I. Connolly is watching the feed with Dr. Patel. They're both holding their breath. On screen, Arthur is sleeping peacefully. His monitor shows normal sinus rhythm, oxygen saturation 96%. And then, 47 seconds later, his chest stops moving. The oxygen saturation alarm doesn't sound immediately. There's a 10 to 15 second delay built into the system to avoid false alarms for movement. But at the 60-second mark, the alarm begins to beep. Arthur's SpO2 is dropping. 90%, 85%, 80%. D.I. Connolly is on the radio. All units move now. Patient in room 18 is in respiratory arrest. Medical team respond. Arrest team go. 4 officers sprint into the building. The hospital's rapid response team is already moving. They'd been briefed and positioned on standby. They reach Arthur's room in 38 seconds. A nurse begins bag valve mask ventilation. Arthur's oxygen saturation starts to climb. He's going to survive. Elizabeth is walking back toward room 18. She'd been at the nurse's station, charting. She has a confused expression on her face. Why is everyone running? When she sees the response team entering Arthur's room, she moves toward them. What's happening? I just checked on him 20 minutes ago. He was fine. D.I. Connolly steps out of the stairwell. Elizabeth Marsh, I'm Detective Inspector Sarah Connolly, Greater Manchester Police. I'm arresting you on suspicion of attempted murder. You do not have to say anything, but it may harm your defense if you do not mention when questioned something which you later rely on in court. Anything you do say may be given in evidence." Elizabeth's face goes white. She looks around, at the officers, at her colleagues, at the cameras. She knows. She understands exactly what's happened. She doesn't say a word. She extends her hands for the cuffs. Arthur Whitfield was intubated and transferred to the ICU. He regained consciousness 4 hours later with no memory of what had happened. He was extubated the following day. The vecuronium in his system had been detected immediately. Blood samples drawn at 2:43 a.m. showed clear evidence of the drug. The syringe recovered from Elizabeth's pocket tested positive for vecuronium bromide. Arthur went home 6 days later. He lived another 3 years before passing away from natural causes at age 84. He was Elizabeth Marsh's final victim, but he wasn't her last. The trial began in September 2019 at Manchester Crown Court. Elizabeth was charged with 17 counts of murder and 1 count of attempted murder. The prosecution's case rested on 3 pillars: the statistical evidence showing the cluster of deaths on her shifts, the forensic evidence of vecuronium in the exhumed bodies, and the CCTV footage of her injecting Arthur Whitfield. The defense argued that the statistical correlation was coincidence, that the trace amounts of vecuronium could have been the result of laboratory contamination or post-mortem degradation of other compounds, that the video was unclear and open to interpretation. But then the prosecution played the full footage, not just the injection, but the aftermath. Elizabeth returning to Arthur's room 4 minutes later. The way she hesitated in the doorway for just a moment before calling out, "He's not breathing!" The way she performed CPR, competently, professionally, but without the urgency you'd expect from someone genuinely trying to save a life. And then they called Dr. Patel to the stand. Dr. Patel testified about her suspicions, about the log she'd kept, about the conversation she'd had with Elizabeth in December 2017, when she'd casually mentioned to Elizabeth that they were having an unusual number of deaths on the night shift. Elizabeth's response had been immediate and defensive. "You're not blaming me, are you? I did everything right. I always do everything right." Dr. Patel described how Elizabeth had then broken down crying, how she talked about how hard it was to lose patience, how she sometimes felt like she was cursed, like death followed her. Dr. Patel had comforted her, had told her it wasn't her fault, had sent her home early to rest. Now, on the witness stand, Dr. Patel's voice broke. "I told her it wasn't her fault. I actually said those words to her, and all the while she was the one doing it." The prosecution also presented evidence from Elizabeth's personal life, her affair, her depression, her increasing isolation. They brought in a forensic psychiatrist who testified about healthcare serial killers, about how they often feel powerless in their own lives and seek control through their work, about how the act of causing a crisis and then responding to it provides a temporary sense of purpose and validation. Elizabeth never took the stand. Her lawyers advised against it. Instead, she sat in the dock, expressionless, while victim after victim's family testified about their loss, about the phone call in the middle of the night, about the nurse with tears in her eyes who told them she'd done everything she could. The trial lasted 7 weeks. The jury deliberated for 4 days, guilty on all counts. At sentencing, the judge, His Honor Judge Marcus Bellamy, addressed Elizabeth directly. "You were entrusted with the most sacred duty in medicine, to care for the vulnerable. Instead, you betrayed that trust in the most profound way imaginable. You murdered 17 people under the guise of caring for them. You robbed them of their lives and their families of their loved ones, and you did so not out of malice, but out of a pathological need for attention and validation. That, in many ways, makes your crimes even more disturbing." He sentenced her to 17 concurrent life sentences with a whole life order. Under British law, this means Elizabeth Marsh will never be released from prison. She will die behind bars. Elizabeth showed no emotion as the sentence was read. She was led from the courtroom without looking at the gallery where dozens of her victims' family members sat watching. But the story doesn't end with the trial. In the months after Elizabeth's arrest, St. Raphael's Medical Center conducted a comprehensive internal investigation. They examined their drug inventory systems, their staffing protocols, their mortality review processes. They hired an external consulting firm to assess their safety culture. The findings were damning. The hospital had multiple safeguards in place, but each one had a workaround. Drug inventory was checked daily, but if a nurse said they'd wasted a dose, dropped a vial, contaminated a syringe, that was simply documented and accepted. Mortality reviews were conducted, but they focused on medical decision-making, not on whether the deaths themselves were suspicious. Surveillance cameras existed in hallways, but not in patient rooms because of privacy concerns. Most critically, the hospital had a culture of trusting its staff. When Dr. Patel had first raised her concerns, she'd been told she was overreacting. When the Mortality Review Board had noted the statistical cluster, they'd attributed it to bad luck. No one wanted to believe that a colleague, a friend, someone they had worked beside for years, could be a murderer. The hospital implemented sweeping changes. Neuromuscular blocking agents are now stored in automated dispensing cabinets that require biometric authentication and supervisor approval for each dose. Every patient room in the ICU and cardiac care unit now has a camera that records continuously, with footage retained for 90 days. Mortality reviews now include an analysis of which staff members were present for each death. And most importantly, staff are trained to speak up if something feels wrong, even if they can't articulate exactly what it is. These changes came too late for the families of Elizabeth's victims. They sued the hospital for negligence, for wrongful death, for failing to protect their loved ones. The hospital settled all 17 cases out of court for a total of £14.3 million. But money doesn't bring back the dead. It doesn't erase the knowledge that your father, your mother, your husband died not because their heart gave out, but because a nurse decided to kill them. Margaret Chen's daughter, Susan, became an advocate for patient safety reform. She lobbied Parliament to create a national database of healthcare workers under investigation for patient harm, something that didn't exist in 2018. If Elizabeth had been investigated at a previous hospital and simply moved on, there would have been no record. Susan pushed for what became known as Margaret's Law, requiring mandatory reporting of suspicious patient deaths to a central authority. The bill passed in 2021. Thomas Wickham's widow, Patricia, never recovered. Friends said she became obsessed with understanding why her husband had been targeted. She attended every day of Elizabeth's trial. She visited Thomas's grave weekly and spoke to him, telling him what was happening as if he could hear. She died of a stroke in 2020, 18 months after the trial ended. Her children said the stress had killed her, that Elizabeth had taken both their parents. Harold Pemberton's son, David, wrote a book about his father's death and the investigation that followed. It's called The Angel of Death Ward, and it's a searing indictment not just of Elizabeth, but of a healthcare system that made her crimes possible. In it, he poses a question that haunts everyone involved. How many deaths did Elizabeth cause before October 2016? She'd been a nurse for 19 years. Had there been other suspicious deaths at other hospitals? The police investigated. They found 3 possible cases at her previous employer, but the evidence was inconclusive. The bodies cremated, the records incomplete. We'll never know the true body count. Dr. Patel left St. Raphael's 6 months after the trial. She told colleagues she couldn't walk those halls anymore without seeing the faces of the patients she'd failed to protect. She moved to Edinburgh and now works in medical education, teaching young doctors about patient safety and how to recognize the warning signs of healthcare-associated harm. She gives lectures titled "When Care Becomes Killing" and "The Nurse Who Murdered My Patients." In one of these lectures, she says something that captures the essential horror of this case. We teach medical students to trust their colleagues. We emphasize teamwork, collaboration, mutual respect. And 99.9% of the time, that's exactly right. But that 0.01%, the healthcare worker who is harming patients, they rely on that trust. They weaponize it. And by the time you realize something is wrong, people are already dead. D.I. Connolly, the lead investigator, retired from Greater Manchester Police in 2022. In her exit interview, she named the Elizabeth Marsh case as both her most important and her most disturbing. "I've investigated murders where the motive was greed, rage, revenge," she said. But this, she killed people because it made her feel good about herself, because she liked the attention. That's a kind of evil I still can't fully comprehend. The psychiatric evaluation of Elizabeth Marsh, conducted after her conviction, revealed a woman with narcissistic personality traits, depression, and what the evaluating psychiatrist called a profound emptiness that she attempted to fill through her role as a caregiver. She scored high on measures of empathy, ironically, but the empathy was performative, designed to elicit responses from others rather than representing genuine concern. She viewed her patients not as people, but as opportunities for validation. When asked by the psychiatrist why she'd done it, Elizabeth gave an answer that was both chilling and pathetic. When someone codes, everyone focuses on you. You're the most important person in the room. Everyone listens to you. Everyone depends on you. For those few minutes, you matter. She's currently incarcerated at HMP Bronzefield, a women's prison in Surrey. She's kept in protective segregation because several inmates have threatened her, even in a prison full of criminals. Harming elderly patients is considered beyond the pale, She's reported to spend her days reading and writing letters to her children, who have not responded. Her husband divorced her in 2020 and has legally changed his and their children's surnames. As far as the public record shows, she's had no visitors since her incarceration began. She will turn 65 in 2043. She will turn 75 in 2053. And if medical science grants her a long life, she will die in prison decades from now, having spent more years behind bars than she spent as a nurse. But the question that haunts everyone who studies this case is simple and terrible. How many Elizabeth Marshes are out there right now? Healthcare serial killers are vanishingly rare. The best estimates suggest one active case per decade in the entire UK, but the structure of healthcare makes their crimes uniquely difficult to detect. Patients in hospitals are expected to die sometimes. Deaths are reviewed, but the default assumption is natural causes. By the time a pattern emerges, as it did with Elizabeth, the killer has often already claimed multiple victims. In the aftermath of the Marsh case, hospitals across Britain reviewed their mortality data looking for similar clusters. 3 other nurses were investigated. 1 was exonerated completely. The deaths on her shifts were genuinely coincidental. 1 was found to have been negligent but not criminal, and 1 case remains under investigation as of this writing. The psychological profile of healthcare serial killers is remarkably consistent. They're often described as dedicated, caring professionals. They volunteer for extra shifts. They're good in emergencies. They form close relationships with families. They're the last person anyone would suspect, which is precisely why they get away with it for so long. They also tend to escalate. Elizabeth's first confirmed kill was in October 2016. By the time she was caught in April 2018, 18 months later, she'd killed 17 people. Early in that timeline, she was killing once every few weeks. By the end, it was multiple times per month. The psychological reward she received from each murder was diminishing, requiring more frequent acts to achieve the same emotional payoff. If she hadn't been caught, the forensic psychiatrist estimated she would have continued indefinitely. Eventually, she would have made a mistake, been seen by a family member, left more obvious evidence, chosen a victim whose death was so inexplicable it triggered immediate investigation. But how many more would have died first? 5, 10, 20? There's a particularly disturbing detail in the case files that didn't come out at trial because the judge ruled it prejudicial. In Elizabeth's locker, police found a notebook. It contained names and dates. 17 names, 17 dates, and next to each name, a small check mark. She was keeping score. Forensic psychologists debate whether this represents organization and premeditation, suggesting the murders were carefully planned, or compulsion, suggesting she couldn't help herself and was simply documenting what she'd already done. The truth probably lies somewhere in between. Elizabeth knew what she was doing was wrong. She knew it was murder, but she did it anyway because the psychological reward outweighed her moral inhibitions. This is what makes her so terrifying. She wasn't insane by legal definition. She knew right from wrong. She simply chose wrong because it felt good. The families of her victims often ask, did their loved ones suffer? The medical answer is complicated. Vecuronium doesn't cause pain, but it causes paralysis. If the patient was deeply asleep when Elizabeth injected them, they likely never woke up. Their oxygen saturation dropped, they slipped into hypoxia, and they died without ever regaining consciousness. This is the merciful scenario. But if they were in light sleep, or if the injection itself caused them to wake, they would have experienced several seconds of consciousness while unable to move or breathe. They would have felt their chest tighten, felt themselves unable to draw air, felt panic. And then, as hypoxia set in, confusion and disorientation before losing consciousness. This would have lasted perhaps 30 to 45 seconds. Not long, but long enough to know something was terribly wrong. We can't know which of Elizabeth's victims experienced which scenario. The CCTV footage of Arthur Whitfield shows him still sleeping peacefully when his chest stopped moving. He likely never woke, but others, we simply don't know. This uncertainty is its own form of torture for the families. There's a broader question here about medical trust. When you're admitted to a hospital, you're placing your life in the hands of strangers. You trust that the nurse adjusting your IV is helping you, not harming you. You trust that the doctor prescribing your medication has your best interests at heart. You trust that the system, the checks, the balances, the regulations will protect you. The Elizabeth Marsh case shattered that trust for thousands of people. Patient complaints at St. Raphael's spiked after her arrest. People refused to be admitted overnight. They demanded family members be allowed to stay 24 hours a day. They questioned every medication, every injection, every treatment. It took years for the hospital to rebuild its reputation. And it's not just St. Raphael's. Anytime a healthcare serial killer is exposed, it damages trust in the entire profession. Nursing organizations in the UK released statements after Elizabeth's conviction emphasizing that she was an aberration, that the overwhelming majority of nurses are dedicated professionals who would never harm a patient. But the public's faith had been shaken. In some ways, Elizabeth Marsh's legacy is a healthcare system that's more vigilant, more transparent, more willing to investigate suspicious patterns. The reforms implemented after her case have likely prevented future deaths. Margaret's Law has identified 3 healthcare workers who were under investigation at one hospital and attempted to transfer to another without disclosing the investigation. They were stopped. But the cost of those reforms was 17 lives, 17 people who went into the hospital expecting to go home, who trusted their caregivers, who never suspected that the kind nurse with the warm smile was the last person they'd ever see. Harold Pemberton, who'd served his community as a postal worker for 40 years. Margaret Chen, who'd come to England from Hong Kong in the 1960s and built a life for her family. Thomas Wickham, who'd been days away from going home to his wife. And 14 others whose names deserve to be remembered. Patricia Crawford, James Monroe, Dorothy Hayes, William Foster, Anne Sullivan, Robert Pritchard, Ellen Walsh, George Davidson, Mary Thompson, Charles Bennett, Sarah Mitchell, Henry Cooper, Grace Anderson, and Joseph Clark. They were grandparents and parents and spouses and friends. They had lives and stories and people who loved them. They deserve to live. They deserve to recover and go home and have more birthdays and Christmases and ordinary, beautiful, unremarkable days. Elizabeth Marsh took all of that from them, not in a moment of rage or passion or even greed, but coldly, deliberately, for no reason more profound than her own psychological gratification. She is, in the most literal sense, a monster, but she's a monster who looked exactly like everyone else, who smiled and laughed and cried and seemed, in every observable way, normal. That's what makes this case so disturbing. The evil wasn't obvious. It was hidden behind a mask of compassion. And somewhere, right now, another healthcare worker is wearing that same mask. We don't know who they are. We don't know where they work. We don't know how many people they've already killed. But if history teaches us anything, it's that Elizabeth Marsh wasn't the first, and she won't be the last. The most we can do is remain vigilant. Worry-immense question patterns. Speak up when something feels wrong. Trust the data even when it contradicts our instincts about someone's character. Because as Dr. Patel learned, as all of us learned from this case, sometimes the person you trust most is the person you should have feared. In the end, Elizabeth Marsh's story is a reminder of a dark truth. The capacity for evil exists in everyone, even those we trust with our lives. The difference between most people and Elizabeth is that most of us never act on our darkest impulses. We have empathy, conscience, fear of consequences. Elizabeth had none of that, or she did, and she simply didn't care. She sits in her cell tonight, as she has for the past 6 years, as she will for the rest of her life. Does she feel remorse? Does she understand the magnitude of what she's done? Or does she still, in the privacy of her own mind, think of herself as the hero of her own story? We'll never know. She's never spoken publicly about her crimes, never given an interview, never expressed regret to the families. Her silence is perhaps her final act of cruelty, denying the families even the small comfort of an apology. But the families don't need her apology. They've moved forward without it. They've created foundations in their loved ones' names. They've advocated for change. They've ensured that Harold and Margaret and Thomas and all the others are remembered not just as victims, but as people whose deaths meant something, whose deaths forced a broken system to confront its failures and become better. That's the only light in this very dark story, the only redemption in this tragedy, that from profound evil came meaningful change, that 17 deaths might prevent 1,700 more. It's not enough, it will never be enough, but it's something, and in the end, it's all we have. The woman in the blue scrubs, walking through Ward 7C, adjusting the IV stands, smiling at her patients, she's still there, not at St. Raphael's, not in Manchester, but somewhere, in some hospital, on some night shift, wearing that same warm, practiced smile. And the only question that matters is, will we catch them before they kill again?